Good afternoon, everyone, and welcome to today's webinar. My name is Kelly McCarthy, Communications and Social Media Manager with the Canadian Cancer Survivor Network, and I will be moderating this session. Today's webinar, What is New for the Prostate Cancer Patient with Non-Metastatic Castration-Resistant Prostate Cancer, will cover the basics of advanced prostate cancer, what it means to have non-metastatic castration-resistant prostate cancer, and the new treatment options now available for this disease space, and the prognosis for patients in this state of disease. We are pleased to welcome today's presenter, Dr. Robert Hamilton, urologic oncologist at Princess Margaret Cancer Centre and associate professor in the Department of Surgery Urology at the University of Toronto. Dr. Hamilton's clinical and research interests are in prostate cancer and testicular cancer. Dr. Hamilton trained at the University of Toronto and has completed a Master's of Public Health at the University of North Carolina at Chapel Hill and a research fellowship at Duke University. He has also completed a fellowship at Memorial Sloan-Kettering Cancer Centre. We would also like to thank our sponsor, Janssen, for making today's webinar possible. Following Dr. Hamilton's presentation today, we will have a question and answer session. During the webinar, you can type your questions into the window on the right of your screen. Questions will be addressed at the end of the presentation. On behalf of the Canadian Cancer Survivor Network, I would like to thank you for attending today's webinar. For almost 9 years, we have been working to help cancer patients and survivors learn about health system complexities, connect with others to plan action, and act to promote best care and healthier survivorship. If you'd like to learn more about CCSN, please visit survivornet.ca. Today's webinar will be recorded and will be available in full tomorrow on the CCSN YouTube and SlideShare accounts. Links to both will be sent to registrants using their registered email. To keep informed about upcoming webinars, sign up for the CCN newsletter at survivornet.ca. And with that, I will pass things along to Rob to begin his presentation.
Well, thank you very much, Kelly, and thanks to everyone who's joining live or who may be watching this later. And special thanks to the Canadian Cancer Survivor Network for hosting this topic. And you know, it's a very interesting time for prostate cancer. I think that's the most important take-home message, is that the rate of discovery and improvements for this disease, prostate cancer, especially advanced prostate cancer, we have not seen this in decades. And so it's a very exciting time. And in fact, it's hard to keep up, whether you're a patient or a clinician. The pace of change is so rapid. And so today we thought we'd pick one state within prostate cancer and just talk about what is new for patients with this so-called non-metastatic castration-resistant prostate cancer, and we'll go through, you know, what that means and what the new information is. So what I thought we would talk about today, well, it's always, you know, I assume most people who are tuning in either have prostate cancer or have a loved one or a friend, relative with prostate cancer, and so you may be familiar with background, but it's always good to go back and just remind ourselves of some of the basics of prostate cancer. We'll then define what this state of castration-resistant prostate cancer means, why patients arrive at that particular state. We'll talk about the subcomponent of that castrate-resistant prostate cancer that we call non-metastatic prostate cancer, and what happens if we don't treat non-metastatic prostate cancer. We'll talk about some of the predictors, or how we predict how quickly a patient may go on to develop metastasis. We'll talk about how we detect metastasis currently in 2019, and then also how maybe moving forward that might actually change with the advent or further dissemination of these PET scans that I'll tell you a little bit about. And then finally, the bulk of the talk will be spent about the exciting new findings from these 3 major studies that show that we can actually prevent the onset of metastasis for patients in this CRPC non-metastatic state. So with that, just a few slides on the background of prostate cancer. And I think, as I said, most people tuning in probably know this, but it's always good to go over this. And prostate cancer remains the most common solid cancer among men. And the latest statistics now is that for every 9 men, 1 of them will get diagnosed in their lifetime. And there's about 23,000 new cases that are going to be diagnosed in Canada this year. So prostate cancer remains a major problem across the population of Canada, and men in particular. The good news is that, you know, many prostate cancers do not lead to death. However, because of its prevalence, it's still the third leading cause of cancer death for men. So, prostate cancer is a major public health concern, and thankfully we are making major advances in prostate cancer, and particularly in the advanced stage, where we can hopefully continue to make this not the third leading cause of death and become lower in terms of the risk of dying of the disease. So there are, every patient has a different journey across their prostate cancer. What I'm showing here is probably the most common journey, and many of you tuning in may be familiar with this, and I think it's good to just show, we're going to spend most of the rest of the day talking about what's over here on the right-hand side, but just as a reminder, most people are diagnosed with an elevated PSA level, and they find out they have prostate cancer, and the majority undergo either surgery or radiation, and hopefully that makes the PSA go down to 0, and hopefully stay for 0 for a very long time, forever. But in a subset of patients, maybe even as high as 40% of patients, the PSA will return and starts to rise again. And sorry, my screen was frozen there for a second. There we go, now it's unfrozen. And so in as much as 40% of patients, the PSA starts to climb, and it means we have to do something else. And the most common way to control the disease at that point is through what's called androgen deprivation. Androgens refer to the male hormones, the most common being testosterone is what most people are familiar with. And by depriving the tumor of testosterone, it's like taking the food away, and the cancer starts to regress again. To look at it another way, we think of the goals of how we treat advanced disease, and we basically block or reduce the testosterone through two ways. One is to reduce the absolute amount of testosterone in the body, and the idea is to get it to, and unfortunately in the medical community we use this awful term, and actually interestingly in social media there's been a lot of appropriate pushback on this term that dates back to the Nobel Prize winning days when we first discovered that this is how we could control prostate cancer. We've used this term castrate, which we undoubtedly should get away from, but nonetheless it's the one we still use, where we lower the testosterone levels to a level as if we had performed an orchiectomy, meaning removing both testicles. And ideally that testosterone level gets down to less than 1.7. So that's one way to treat advanced disease. The other way is to block the effect of testosterone by blocking the testosterone receptor, or so-called androgen receptor, and we'll talk a bit about both of these mechanisms going forward. There are probably several of you on the webinar who are familiar with ways in which we do this androgen deprivation therapy. The most common is through an injection of a medication, and I've listed the most common ones here: Lupron, Eligard, Zoladex, Trelstar, Superfect. And then it's probably beyond the scope of today's webinar, but there's two different types of injections. There's agonists and antagonists. The antagonist is called Firmagon. I think for today, we just have to group these by saying these effectively lower the level of testosterone in the body. And then we have anti-androgens, or androgen receptor blockers, the most common of which is Casodex and probably bicalutamide. Many of you are familiar with that. And there's some older ones like nilutamide and flutamide and soproterone, but they effectively block the receptor. And these are the two ways, and we've been doing this the same way for 40 years or more. This is how we've been blocking the testosterone effect in the body, and hopefully getting that prostate cancer to go into remission and stay in remission for a long time. The problem is, and unfortunately, if patients live long enough, eventually the tumor begins to outsmart that androgen suppression, and we enter a phase that we call castration resistance. So despite having castration levels of testosterone, the tumor learns how to grow. And usually we see that reflected in the PSA. The PSA starts to rise. But alternatively, we can also identify that by having new metastasis show up despite having a castrate level testosterone. And now we're in this new state of disease that we call castration resistant disease. And so the most common questions patients ask, and rightfully so, is, well, why does it happen? And I don't want to get into too biological of a discussion, but it's basically 4 mechanisms that lead to it. And one is that the tumor itself learns to make its own food. So it learns to make its own androgens or testosterone. Another way is that the tumor increases its own levels of this androgen or testosterone receptor, so that even though you may have a small amount of testosterone floating around in the bloodstream, by increasing the number of receptors, the tumor can still get enough food in order to grow and divide. And then the third way is that the tumor actually may mutate or alter the receptor so that it becomes have much higher affinity for the testosterone. So the bind with the testosterone becomes much stronger, and it can overcome that low testosterone level. And then the final way is the tumor can actually outsmart altogether, and it can say, you know what, I don't need testosterone to grow, and they find what we call non-androgen dependent ways to grow. So that's the most common way that the tumors overcome the castration by reducing testosterone levels. And you know, why is it important? Why do we put this label on this certain disease state? And it's because, unfortunately, when you enter this castration resistant state, it signifies a period of more accelerated growth of the cancer. And if the cancer has not yet metastasized to other parts of the body, unfortunately, it means that there's a much greater likelihood that the metastasis will occur in the near future. And then the final point is that in the world of prostate cancer, unfortunately, it means once you enter that castration resistant state, we now are more able to predict the time at which a patient may die of prostate cancer, because it signifies a more aggressive disease state. And we'll talk a little bit more about this, but that window tends to be, obviously everyone is a little bit different, but it tends to be in that 3 to 4 year age range. Now, within this category of castration-resistant disease, we group things as either metastatic or non-metastatic, and so I thought I would just take 1 minute to define what metastatic means, and I think most on the call will know that, but it is effectively the development of another malignant growth of the prostate cancer at a distance from the actual prostate itself, whether you've had your prostate gland removed or not. And so the most common location is for the lymph nodes. The second most common location is to be in the bone. And the third most common is in the liver or other what we call visceral organs, other organs other than the prostate gland. So when you have disease there, that's what we call metastatic. If you don't have any evidence of that disease, then you are labeled as being non-metastatic castration resistant, and that's the group that we're going to talk about today. And basically, to fall into that group, you have to have 3 things. You have to have that serum testosterone level below 1.7. So again, that awful term we use, castration, to get this testosterone that low. You have to have evidence of a rising PSA, but no evidence of any metastatic disease, and therefore, by definition, you are non-metastatic castration-resistant prostate cancer. And why do we make that distinction other than just describing the radiographic findings? It actually has some translation into not only how we manage it, but what we're able to tell patients about where they are in their prostate cancer journey. And so if you have metastatic castration-resistant prostate cancer, the time at which one has left in terms of survival with their prostate cancer is quite predictable and shorter, unfortunately, at 36 months. Often metastatic patients are symptomatic and they can have pain. They can suffer from fractures from their prostate cancer, and sometimes that leads to immobility. I guess the good news is, and we're not talking about this today, but there's been many advances in the treatment of metastatic castration-resistant prostate cancer, and we now have 5 approved drugs that we can use to treat metastatic castrate-resistant prostate cancer. Non-metastatic, the course of the disease is much more variable, and it's actually harder to predict how the non-metastatic prostate cancer is going to live. As I alluded to, generally, the survival is in that range of 48 to 60 months, so certainly much longer than the metastatic disease. Fortunately, patients with non-metastatic disease often do not have symptoms, and the consequences of having non-metastatic disease, the physical consequences of having non-metastatic disease, are much less than if you have metastatic disease. Now, I've purposely left this box blank because up till recently being the last 3 years, we really had no effective treatments in this box for non-metastatic castration-resistant prostate cancer. But now we have, and this is what the bulk of the remainder of the talk will be about, is that we now have 3 effective therapies to treat patients who are in this non-metastatic CRPC space. So a question that often comes from patients who are in this non-metastatic CRPC is, well, what if I didn't treat this at all? What if we just stayed on the androgen deprivation therapy and we just followed things? What's likely to happen? And we know from several studies that on average, about half of patients will eventually develop metastasis by about 3 years. And as I mentioned, sometimes those metastases can lead to pains and immobility. And so we can counsel patients that by about 3 years, there's a 50% chance that the metastases will subsequently develop. And we can actually further hone our prediction of when these metastases are going to develop. And through studies, we know that there are some factors that are associated with a faster rate of developing metastasis. The original Gleason score of the prostate cancer, which is how we grade through the microscope, how we grade how aggressive one's prostate cancer is, the absolute PSA level at the time that the patients are diagnosed with the CRPC disease. And then the most important one by far is this rate of rise of PSA. So how fast is the PSA rising? And we categorize this as PSA doubling time. So the faster, the quicker the PSA doubles, the more likely you are to develop metastasis. And so we have several nice studies that show as the PSA doubling time gets below, remember, shorter doubling times are worse. So as the PSA doubling time gets below 10 and 8 months, the risk of developing metastatic disease increases quite exponentially. And so we pay a lot of attention when you are in the non-metastatic CRPC space to how fast your PSA is doubling, because that gives us the most important insight into how quickly the disease may be progressing. And this is reflected in our Canadian Urological Association guideline, where we categorize this as patients who have a rapid rise or who have a slow rise. So if the PSA doubling time is rapidly rising, less than 10 months, or the PSA is absolute PSA is over 20, then the guidelines suggest that you can feel free to bring this up with your physician who's following you, is that the guidelines suggest that the imaging really should be every 3 to 6 months in hopes of catching any metastatic disease early so that we can initiate treatment early. If the PSA is rising more slowly, greater than 10 months, then you only have to be imaged in the range of every 6 to 12 months, depending on how fast it is in that greater than 10-month category. So I'm going to spend a little bit of time, because this space is changing rapidly, almost as fast as the therapeutic space in prostate cancer. The imaging space is changing fast in prostate cancer, and I think it's important for patients and survivors to hear about this, if only briefly. For decades, we have used, and I'm sure many on the webinar have had one of these scans. Even if you haven't had cancer, you may have had one of these scans to go for investigation. But CT scan remains the most common way that we image prostate cancer. Bone scan is the second most common way in which we image prostate cancer, with the idea being to try and find the areas that the cancer has metastasized to. Now, the problem is, and we've known this for a long time, CT scans and bone scans are really not sensitive, is the word we use in the medical literature, for detecting the tiny amounts of metastasis when they first start to spread outside of the prostate cancer itself. And there have been several papers written about this concept that we really need to have a more modernized imaging approach for advanced prostate cancer, because these scans are letting us down in terms of ability to detect small amounts of disease. So we're now officially entered into an era where we have access to what's called PET scans, positron emission tomography. And you can think of them as just a fancier CAT scan that has a special type of tracer that's targeted towards specific parts of the body or specific molecules in the body. The one that is getting the most attention by far is this one called PSMA, or prostate specific membrane antigen, and by far is the most promising to suggest that we can detect prostate cancer in the body at much, much smaller levels than bone scans and CAT scans. And the reality is we're still relatively immature in our understanding of PSMA. We don't know its actual function in the cell, but what we do know is that it's significantly overexpressed in prostate cancer, especially in advanced disease, and this translates into it vastly outperforming. So this PSMA-based PET scan vastly outperforms conventional CAT scans and conventional bone scans in finding really small amounts of prostate cancer throughout the body. And I bring this up by way of saying that, how we have up till now diagnosed a patient with metastatic disease versus non-metastatic disease has been relatively crude with CAT scans and bone scans. And I think we're going to get much better in the next, say, 5-year horizon. Unfortunately, the PSMA PET scans. They're not approved or are funded in Canada or in the US. Currently, they're available through special means such as clinical trials or provincial registry programs. But I think the landscape in the next 5 years will change, and we'll probably be talking about PET scans much more. And so I thought it was worth putting in here just so that any survivors or family members of survivors are listening. They have some knowledge about this, and they can bring this up with their clinician at their next visit. So, as I mentioned, is there a way that we can prevent metastases once we're in that CRPC non-metastatic space? So you have CRPC disease. Fortunately, the scans don't show that you have metastases as yet. And is there anything that we can do to prevent the development of those metastases? And up until recently, the answer was not really. We had no proven way to prevent metastases. We as clinicians often tried some things. So often we would add back in an anti-androgen such as Casodex, as I mentioned earlier. If that didn't work, we could try, after we added it in, we could try taking it away. Sometimes that led to a small PSA response. We could add other medicines like ketoconazole or corticosteroids. And if you're lucky, you may get a 30% decline, like about 30% of patients will get a decline in their PSA, but that always tended to be relatively short-lived. And no matter, even if you did get a PSA response, all of the small studies that looked at this cocktail of medicines, unfortunately, never really translated into proving that we could delay metastasis, and certainly didn't translate into proving that we could prolong survival. And so for decades, this is all we had, and we really admitted that it wasn't very effective. Now, as of 3 years ago, in the last 3 years, we now have some what we call level 1, so very high level randomized controlled trials, what we call phase 3, so the highest level of evidence, phase 3 studies looking at new compounds, apalutamide, enzalutamide, darolutamide, in thousands of patients in total. Each trial asking the question, if we add this drug to our conventional androgen deprivation therapy that we're on, in the CRPC non-metastatic space, can we prolong the time before our metastases show up in the body? And the answer is absolutely yes. And this is an unequivocal answer that we learned from these trials. And the answer is that the patients who received the drug versus those who did not receive the drug had a 2-year prolongation before their metastases showed up. And so for that particular endpoint of delaying the time to metastases, each of these trials and each of these drugs is a home run, no matter how you measure it. And the delays in time to metastases are very impressive. Of course, the next question that people always ask is, well, does that translate into survival? And we'll talk some more about this, but the reality for now is that it is too early to know, because the trials are relatively new. It's too early to know if actually the overall survival is improved, but for certain we can say that we prolong the time to the development of metastasis. And so that often raises the next question from patients is, well, is there actually merit in preventing metastasis? Does it matter if I develop a metastasis or not? And I and many people argue that yes, it does, because metastases do matter. And this is the first line is a medical terminology, this hematopoiesis. But when a cancer invades into a bone, it makes the bone marrow less able to do what it normally does, which is produce the blood cells, including the red cells. And that can lead to anemia or a low hemoglobin level, which can lead to fatigue, among other things. Metastases in the bone can lead to pain. Metastases in the bone can lead to decreased mobility, which is important for patients with prostate cancer. And then it can lead to what we in the medical community call this skeletal related events, which is a catch-all term for fractures or compression of a spinal cord that has metastatic tumor deposits in it. And it can lead for the need for surgery and or radiation therapy. And all of these skeletal related events we know translate into pain for patients. They translate into reduce what we call quality of life. QOL is the short form for quality of life. And skeletal related events, we know this translates into decreased survival. So to any extent that we can avoid these or delay these are very important outcomes. And as I'll show you in the next slide, the burden of metastasis, we know from other studies and from other cancers, is directly associated with survival. We just haven't as yet seen it in those 3 specific trials that I showed earlier for these castrate-resistant prostate cancer non-metastatic trials. Now, we do have some what we call surrogates to suggest that delaying metastasis may translate into prolonging survival, and this was data that was shown at the recent American Society of Clinical Oncology meeting that showed that and unfortunately it's filled with acronyms, this poster, but the metastasis-free survival, so the time to metastasis, directly correlated with the overall survival. So the longer the time before the patient developed metastasis, the longer the time before the patient passed away from their prostate cancer. And so that's what we expected would happen. And for the first time, we have some data to suggest that that's true. This was another poster abstract submitted by the Alberta group that looked at within their province, 159 patients with non-metastatic castrate-resistant prostate cancer, and what they found again was that metastasis-free survival strongly associated with overall survival. So again, there may be merit in preventing metastases because that might translate into survival. And the final slide, well, first I'll show this before we talk about the updated Spartan trial analyses. When they first presented the data about these 3 new trials, apalutamide, enzalutamide, and darolutamide, the question was, okay, well, if you prevent metastasis, what happens after the prevention of metastasis? So if a patient was not placed on the active drug and went on to have a metastasis early, they were then put on the active drug. And the question is, well, did they catch up? And did their survival end up being the same as the patient who was placed on the active drug in the first place? And the answer from these trials was a resounding no, they did not catch up. And we can show that schematically here a little bit better, that the patient who was not placed on the active drug with this non-metastatic castrate-resistant prostate cancer, after about 16 months, they went on to develop metastasis, as compared to patients who were on the active drug. They had a longer time before they developed metastasis. And so the question is, by switching the patients over to active therapy after they develop metastasis, do they catch up to these patients that were on the active drug originally? And the answer is no. There is this endpoint called progression-free survival number 2. So the time to the second progression was longer in the patients who were treated upfront with the active drug as compared to patients who were treated upfront with a placebo in these trials. And so that speaks to the importance of trying to identify the patients who are good candidates to go on this active therapies in the CRPC M0 space, because we think we not only prolong the time to metastasis, but we prolong the time to subsequent progression and hopefully prolong the survival for those patients. And this is the final, it's still premature, but this is the final piece of data I'll show you speaking to this. It's from the Spartan trial, which looked at apalutamide in the CRPC non-metastatic space, and it shows a hint that there may indeed end up being a survival advantage for these patients, in the sense that we saw a 25% reduction in the risk of death for the patients treated with the active drug as compared to the patients treated with the placebo. But again, I think the data is still not mature enough as yet from this trial or the other trials to draw a concrete conclusion about survival as yet. But I think a lot of signs are pointing towards a inevitable survival benefit for the patients that are treated with these medicines. And you may say, what about a PSA? And for men with advanced prostate cancer, you all know that you hang on that PSA result very, very carefully, and you scrutinize them, and so you should. And so the good news is that for patients who were treated with the active therapy in these trials, they had very impressive declines in their PSA level. And if you look at the percentage of patients who had over 90% decline in their PSA when they were treated with these drugs, about between half to 2/3 of patients in the trials had very impressive declines in the PSA. So not only are we prolonging the time to metastases, but we're also showing a nice decline in the PSA, which is very encouraging. anytime you see a trial that shows an important benefit such as metastasis or survival, the next question you should ask is, well, what are the side effects and what might be the price that one would have to pay in terms of quality of life? And the important news story from all three of the studies, Spartan, Prosper, and Aramis, is that as best we can tell from within the trial, that the group that was treated with active therapy really had no decrement in their overall quality of life while they're on therapy. And when you compare that, for example, in the Spartan trial to the placebo group, as the patients started to develop metastasis because they weren't getting the active drug, we start to see a decline in their quality of life, probably because the metastases are leading to some of those symptoms I told you about, pain and immobility. And so that translates into a decreased quality of life. And so what we hypothesize is that by treating early, we're able to maintain that quality of life while we prolong the time to metastatic disease. And as I mentioned, it's always good to understand what the side effects are for each of these drugs. And there's a lot of data on this slide, and I don't think we need to go through every individual one. And the problem is when you try to compare these trials, the way the side effects are captured is different within each trial, how frequently, what type of questions that they asked on these trials. So it's very hard to compare. I think the best is to, within each trial, compare the active arm with the placebo arm. And the bottom line is that, yes, there is a little bit more fatigue, a little bit increased risk of high blood pressure and some rash and falls and fractures and this funny term where we call mental impairment, which can be some occasional confusion or a little bit decline in the sharpness of one's cognition. But overall, the conclusion from all three of these studies is that these drugs are safe. And when you consider that patients are in an advanced state of prostate cancer, and I showed you some of the benefits, I think that the relative incidence of these side effects compared to the placebo arm where you do nothing is relatively safe. And obviously, no drug is free of side effects. I think in the grand scheme of medical therapy for cancers, these are relatively safe. And I think the majority of the industry also, industry of clinicians who treats these patients also feels that way as well. So we're just coming up over 35 minutes here. So I think we'll start to wind down. And I think that the take-home points are for patients who have castration-resistant metastatic prostate cancer, and particularly anyone who's on androgen deprivation therapy. I think it's important to stay in close contact with your physician and watch your PSA, because PSA rises is often the first indication that a patient may be transitioning from a castration sensitive to what we call this castration resistant state. And if that happens, then it's important to be screened for metastases. And as I mentioned, that's done today with a CAT scan and a bone scan. Soon, and in many places in Canada, it's possible to even now get some of these PET scans on registry. So soon, these conventional imaging will be replaced by PET scans to improve our detection of metastasis. And for relevant to today's talk, if you find out that you are non-metastatic, it's important that both you and your physician compute the rate of rise of your PSA or your PSA doubling time, because that gives a window into how fast your disease is progressing, and it gives a window into how often you should be imaged in order to try and catch these metastases as early as possible. And then a reminder just to, at any point in your journey, particularly once you reach the castration-resistant state, it's important to bring up to your physician any new symptoms you have, pain, weakness, fatigue, because that may be a sign to your physician that you may be having the start of a metastatic spot, and that would prompt an imaging, maybe earlier than what your schedule would otherwise have suggested. If you have new pain in your right hip, for example, probably that should prompt some imaging to make sure that it's not a metastatic spot if you have castration-resistant prostate cancer. And then the relevance of today's talk is that historically, for patients who had this non-metastatic CRPC, we really had no proven treatments. Now the landscape has changed dramatically, and we have 3 drugs that have met this quote-unquote level 1 level of evidence, and they have benefit for patients, particularly with the rapid PSA doubling time, or PSAs less than 10 months. We know, beyond a shadow of a doubt, that we can prolong the time to metastases. What we don't know, although, as I mentioned, the data is pointing towards this. We don't yet know officially if it can prolong the time to survival, and we need longer time to follow that up. And the final point I'm going to make is that the current status in Canada, I mentioned those 3 drugs that have been studied in the clinical trials, all of which are published in the New England Journal of Medicine. They're at various points in their journey of getting approved and funded in Canada. So if we look at apalutamide, enzalutamide, they have achieved Health Canada approval. Darolutamide has been submitted for approval, but we don't as yet have Health Canada approval. Apalutamide and enzalutamide have undergone provincial review, but no provinces have made a funding decision as yet. So they're not available for reimbursement through the normal mechanisms within provinces, but the pharmaceutical companies have made them available through what's called the EAP, Exceptional Access Program. And so if your physician feels that you are eligible and you may benefit from these drugs, they are available through the pharmaceutical companies until we get provincial Health Canada approval and provincial funding. So I think I will stop there, and my final slide is just a reminder and this is relevant to all patients with cancers. Make sure you have an open dialogue with your physician about how you should be monitoring your prostate cancer, what you should be looking for as you transition through your journey for prostate cancer, what symptoms you should be looking for. And if you have now transitioned into the non-metastatic castration-resistant prostate cancer, I think the overall message is that it's a very exciting time in prostate cancer. And so don't despair, because we have a lot of new therapies and we're coming up with new therapies all the time. And be sure to talk with your physician about whether you may be a candidate for one of these newer therapies in the non-metastatic CRPC space, because there may be an opportunity for you to benefit from some of their advances. So Kelly, I think we'll stop there, and we're a little bit ahead of schedule, which is never a bad thing, I guess. And I'd be happy to take questions if anyone online has any questions.
Great, thank you, Rob. You're right, we will now have our question and answer session. We do have a couple of questions, but just a reminder to everyone listening right now that you can type a new question anytime into the window on your right. So Rob, our first question says, I have metastatic prostate cancer and my PSA rises very quickly, but I respond to ADT injections as well as bicalutamide. My doctor will not recommend me to start apalutamide or other newer drugs. How can I get access to these drugs?
Well, that's a great question, and I mean, just to clarify, so this gentleman has already, by the sounds of it, transitioned into the metastatic place of prostate cancer. I couldn't tell from the question whether he has castration-resistant metastatic prostate cancer or not. Let's assume, for the sake of discussion, that he does have castration-resistant prostate cancer. There are novel therapies that patients in that space are eligible for, and I showed on that earlier slide, there's actually 5 approved therapies. You mentioned the apalutamide is basically abiraterone, enzalutamide, chemotherapy, and what we call radium. Now, it's always hard to answer a question in general, because every patient has to be taken individually, and without knowing the other what we call comorbidities that this particular patient may have, it's hard to know what he would be eligible and appropriate to receive. So for example, and I'll just give you a couple examples, patients who have some heart failure or early heart failure, abiraterone or Zytiga, we know tends to progress heart failure, and so maybe that's not safe for that particular patient to go on. If you have a history of a seizure disorder, for example, enzalutamide, the general guidance is not to place patients on enzalutamide because it lowers the seizure threshold and may put you at risk for seizure. If you have other cardiac comorbidities, or you're older and have other comorbidities, then chemotherapy is not safe to give to patients, particularly older patients. So there may be reasons why your physician has not chosen to place you on one of those more advanced therapies. I guess the general advice is have a discussion with your physician and say, listen, I know that I've heard about these new therapies, I've read about them. Is there a particular reason why you don't think I'm appropriate for those therapies? And is there worth getting a second opinion? And I always encourage my own patients to seek second opinions, and I don't think that there's a disadvantage to that. Gaining knowledge is always a good thing. And in particular, if you're seen at one of the cancer centers that has a lot of high volume experience with treating patients with advanced prostate cancer, I think there's always advantages to that, to having what we call a multidisciplinary discussion. So if you have a urologist, then maybe you see a radiation or medical oncologist to get a different perspective on your prostate cancer. So, without seeing you as a patient myself, I can't answer that specifically, but that's a general answer for someone in your state.
Thanks, Rob. We only have one other question at this time. It is, how can antifungal treat prostate cancer? What is the mechanism of this action?
So that's a great question. And I showed that slide of what we now call largely historical treatments that we used to use to treat this non-metastatic castration-resistant prostate cancer space. And one of them was called ketoconazole. And ketoconazole comes from this family of azoles, which are historically used as antifungals, as this smart listener has made allusions to. And ultimately, the mechanism is by inhibiting synthesis of androgens, and also there is some direct anti-tumor suppressive effects. And it's interesting actually. So ketoconazole works through that mechanism, but unfortunately has a lot of side effects. Gastrointestinal upset being the most pronounced of the side effects. And so patients who were historically treated with ketoconazole had a rough time, and there are also some imbalances with their other what we call adrenal hormones and hormone synthesis from the adrenal gland. And so it's a little bit challenging to get patients through ketoconazole. There's another antifungal called itraconazole, which interestingly has ongoing research and publications that show that there may be some synergy for itraconazole in patients who have castration-resistant disease, but likewise the side effect profile of itraconazole is also a little bit more sinister than the apalutamide, enzalutamide, and darolutamide. And so I think for most clinicians, we favor the newer therapies. If we're going to treat somebody, we favor the newer therapies over these older therapies, including the antifungal class, for that reason.
Great, thank you, Rob, and thank you everyone for. Oh, one other question just popped in. Just finished radiation and on hormone therapy, Lupron as well. Should I be looking at other treatment options?
So again, it's always hard to answer these specific questions. If we assume that this particular man is talking about radiation as a primary treatment for the prostate cancer, and had hormone therapy or androgen deprivation therapy as part of that primary treatment for prostate cancer, I think my advice would be just ride out the course as prescribed by your physician. So usually the duration of hormone therapy after primary radiation therapy can be anywhere from 6 months up to 3 years, depending on your risk status and how your radiation oncologist, how long your radiation oncologist wants to keep you on hormones. But the advice would be, you finished your radiation, finish the course of hormones, and then see what happens to the PSA, and you may find that everything looks great and that you've been cured from your prostate cancer, and then you don't need to pursue any further therapies. Now, if you have, if the question is more that you've had radiation therapy and yet your PSA started to rise and you were placed on hormone therapy to combat a rising PSA, I think that as long as your clinician has ruled out any metastatic disease, the advice for that particular space in 2019 still remains to stay on hormone therapy. You can talk to your clinician about what's called intermittent hormone therapy or intermittent androgen deprivation therapy, which is after the PSA reaches a certain low level for anywhere from 4 months to 9 months of androgen deprivation therapy, you can come off the androgen deprivation therapy and watch the testosterone rise, and then eventually watch the PSA rise. And once the PSA reaches a certain level, many people use 8, some people use 10 or 15, you can go back on the hormone therapy and suppress the PSA down again. The idea being that the overall side effect burden of the hormones is lessened by using it in an intermittent state as opposed to a continuous state. But I think the quick answer to your question is no matter which of those two spaces you're in that I outlined, I don't think at this point you need to be pursuing any new or novel therapy, because there's really not too much new in that particular space where you're in. So I hope that answers your question. It's hard without having you in my office beside me to ask you more questions.
Thanks, Rob. I think we have one more here. Is it important to clear up any dental problems before taking the new drugs?
Great question. So the dental health is not of particular relevance for the three drugs that I discussed today in the non-metastatic CRPC space. However, in the metastatic CRPC space, where we talked about radium-223, well, I didn't talk about it, but that is one of the approved therapies for metastatic CRPC is radium, and in particular, in the metastatic CRPC space, we use a drug called Xgeva or denosumab, which is designed to strengthen the bones for patients who have metastatic disease. And anytime that we are giving a drug to strengthen the bones, the other drug I should mention is also Zometa or zoledronic acid. So those are the two bone strengthening drugs we use, Xgeva and Zometa. And in strengthening the bones, if a bone has an active infection in it, such as the jawbone, which seems to be particularly prone, by giving Xgeva or Zometa, there is a chance of inducing what's called osteonecrosis of the jaw. And so I think that that's what this particular person is asking about is before you embark on either of those therapies, it is important to go and speak with your either physician who's prescribing, your family physician, or your dentist to have a look at your dentition to make sure that there's no teeth that need to be pulled, cavities that need to be drilled, gum integrity that needs to be looked at before you start on one of these therapies. So that's a very good question.
Thanks, Rob. I think that brings us to the end of the question and answer session. So thank you everyone for your questions. That brings us to the end of today's session. If anyone does have any further questions, you can direct them to communications@survivornet.ca and we will pass them along to Rob. We would like to take this opportunity again to thank Rob for presenting and to Janssen for their sponsorship. Just a reminder that this webinar will be available in full tomorrow at the CCSN YouTube and SlideShare accounts. Registrants will receive an email link to the saved webinar. Please feel free to review at your leisure and share with friends, family, and colleagues. Our next webinar, Cancer-Related Lymphedema, What You Need to Know, is scheduled for Thursday, November 21st at 1 p.m. Eastern. To register for that session or future webinars, visit our website at survivornet.ca. And that concludes today's session. Thanks again, Rob, for presenting.
My pleasure.
And thank you everyone for attending. Have a great afternoon.